Okay, everybody, good morning. It's 11 o'clock, so in the interest of everyone's time, we'll get started. I will ask our participants who are from the media to please mute yourselves and turn off your cameras for the recording so that Dr. Blue and Dr. McGeorge are on the screen. Thank you so much. And thank you for joining us for this media availability to discuss the Omicron variant, as well as an update on COVID activity, vaccines, and boosters. So today we have with us Dr. Sky Blue, Sawtooth Epidemiology and Infectious Diseases, and Dr. Laura McGeorge, St. Luke's System Medical Director for Primary Care. So we're here to give you the opportunity to ask questions. Dr. Blue and Dr. McGeorge will provide you with some information about the Omicron variant and an update on COVID activity, vaccines, and boosters, and then we'll open it up to Q&A. When it's time, please raise your virtual hand by clicking the button, and I will call on you. When you hear your name, unmute yourself, provide your name, news organization, and to whom your question is directed. You can also ask questions with the chat feature if preferred. And just as a reminder, please keep yourselves muted and turn off your cameras. And with that, let's get started with Dr. Blue.
Hi, thanks for tuning in, and I really appreciate our colleagues in the media helping to bring accurate information to your listeners, readers, and thank you for your work up to this point. I'm not sure if I can add too much more to what you've probably seen in a lot of other media sources out there, including WHO and CDC. But what I'll do is just kind of give a quick overview, and then probably a lot of that will come up with the questions. Omicron is a new variant of concern, which was initially recognized in South Africa, in the northern provinces of South Africa. It has gotten a lot of attention because of the sheer number of mutations that it has in both the spike gene, which is that outer coating into which our vaccines are directed, but it also has mutations elsewhere. A lot of these mutations we've seen in other variants of concern, but the sheer number has got a lot of individuals' attention. And a couple interesting things that I will point out in that is first that its closest relative before it has come out, if you look at the genetic tree, is from mid-2020. So we haven't seen close relatives along that tree until November of 2021. So nearly a year between its closest relative. And that has a lot of individuals speculating on what was going on in that gap. And certainly there are a lot of experts who make their research career out of studying this and have postulated several ideas of what could fill that gap. And we can discuss their ideas in the question and answers if you want to have that. But I really want to put what we're seeing here in a little bit of context, because on its face, you can say a lot of mutations, which in the past in our variants of concern has had a lot of people jump to, our medications don't work, our vaccines don't work, your previous immunity doesn't work. It's going to take over as the predominant variant. And there's a lot of speculation on this, but the data has not really told us where that's going to go. And there are, when you speculate, there's really some arguments on each side. As you increase the number of mutations on the spike, immunity that has developed from previous infection that was very specific to one variant, or from our vaccinations, which tend to be a little broader immunity, may not bind because of those mutations. And as we've looked at other variants of concern, we do see that there is a reduction in the neutralization capacity when we've looked at a small number of convalescent patients or individuals who have had the vaccination. I anticipate that we will see that with this variant as well, but those experiments are somewhat labor intensive and have not yet been done. When experimentally, a group from a lab in New York put 20 mutations into a pseudovirus, not a real SARS-CoV-2, and they did see as much as a 10-fold reduction in the neutralizing capacity. But they were also looked at the serum of individuals who had been vaccinated after having an infection and found that it was still able to neutralize. And also to put it in context as well, is that we expect this virus to continue to mutate. Every new case will allow the virus to try out some new mutations. That is going to be expected. And because of the nature of the virus, it's an RNA virus, which is prone to mutations. And the virus to put in anthropomorphize is that it wants to just spread. So it's going to look for mutations that allow it to spread, either through those who've had previous immunity or somehow be more transmissible than one of its relatives to allow it to spread. And I think that is also an unknown quality of this variant. It shares some close mutations with Delta in the regard of around what we call the furin cleavage site, which has been associated with some factors that may make it more transmissible. So not only does it have some mutations in the spike, but it also retains some mutations similar to Delta that may keep it higher on the transmissibility. There is a potential that as the virus collects these mutations, it will not be as fit as other viruses. And we've seen this with the Mu variant, which had a lot of attention early on with a lot of mutations, but really seemed to peter out. It did not continue to spread. So those are a couple of the things that we are looking for. Then there's been a lot made about, is this going to be more virulent? Meaning, is it going to make individuals sicker than other variants? And there's been reports on both sides of that. There's reports of individuals who have been sick with this variant, and there's reports, especially the cases that have been recently reported in the United States, have had very mild symptoms. So those are what we're watching for. And from what I've seen of reliable data that's come out of that, they remain unanswered questions. And I believe some of the possible speculation, and other of the speculation, I think is a little less credible, but I certainly don't think any of that is settled. So sorry for more questions than answers in that setting, and we can talk about the nuances of why I make these statements in the question and answer if individuals are so inclined. And I'll keep my opening comments somewhat short and end it there. I'll see if Dr. McGeorge has any comments to open with.
Yeah, thank you, Dr. Blue. Yeah, I just would like to emphasize Omicron or any other variant, regardless. I mean, we do have COVID still in the community. We're in a better situation right now than we have been. But, just again, a reminder to people to be cautious. We have reason for optimism. We're a lot further ahead than we were a year ago. We have much more testing available. There's testing in urgent cares, at doctors' offices, in pharmacies, and then all the health systems, of course, have testing available, and a lot of it is turnaround within a day, or even, of course, some of them, the antigen tests, you can get the results immediately. We now have monoclonal antibodies coming down the pike, likely are more antiviral treatments. So there's a lot of reason to be optimistic, but we do know we have to continue with masking and really good hygiene. I think of around this time of year really being cautious and trying to avoid what I call a super spreader event, and those are really the indoor events. People are loud, you're yelling, you're close to people, and frequently unmasked. Those are really high risk areas, and so especially if you're not vaccinated, but regardless, if you're not vaccinated, or if you're someone who's especially at risk for severe disease with COVID, it's really important to try to avoid those kinds of situations. And again, people getting vaccinated who have not been vaccinated at all, now all the more reason to do that. And of course, I think you all know that adults now can get a booster, and really should get a booster for their vaccines. If you've had the Moderna or the Pfizer, you can go ahead and get a booster at 6 months. If it was Johnson & Johnson, we recommend you get one of the messenger RNA, which again is Moderna or Pfizer, and you should get that at 2 months after your initial Johnson & Johnson or a Janssen vaccine. A couple of other things just to give you an update on what's going on at St. Luke's and in our communities. We are still seeing high hospital volumes as COVID volumes are definitely going down, and we're very happy to see that. We have a lot of high volumes due to non-COVID care. There has been a lot of care delayed, whether it was elective surgeries or colonoscopies, other cancer screenings, management of chronic disease. All of that really had been delayed significantly during the pandemic. A lot of it was, or during that last surge, a lot of it was delayed really because we had to redeploy all of those resources in to take care of COVID patients. So now we're trying to work through that backlog, but definitely our volumes are high as we're doing it. With that being said, we absolutely want people to get back going again with their cancer screenings and making sure that they're getting all their chronic disease needs taken care of, whether it be diabetes or mental health needs, substance abuse. We're just seeing a lot of issues and want people to seek out care. A couple of comments. I think our healthcare worker morale is doing better, less fatigue, less stress. There has been, I think, with this last surge, there was a lot of positive support, which is really helps our teams. And so that support from the community has been greatly appreciated. Other things, just a few other comments, really specific more to St. Luke's. If you go on our website, you can see where boosters are available. We do encourage people to use, if they have a MyChart account, to use those. It makes it super simple to sign up for vaccines. Also makes it simple actually to schedule things like CAT scans and MRIs. You can now self-schedule a lot of things. So I want to remind people of that. Two more comments on other specific things is last year we anticipated a big flu season and RSV season. We did not see that, probably because we had super robust masking and physical distancing last winter. We are not seeing that as much this year, of course, and then we've gone a year without influenza really going around the community much. So we don't know, but there's certainly reason to believe we should be concerned about influenza. And so again, strongly encourage people to get those flu vaccines. You can get it same day as your COVID vaccine. It's not a problem to do that at all. And then last, if you are pregnant or thinking of becoming pregnant, please get those vaccines. We, as you all have heard in the press, have seen hospitalizations, stillbirth, and obviously some unfortunate mortality in pregnant women or pregnant people that are unvaccinated. So please do that to take care of yourself and take care of your baby. And that's all I have to share right now, Joy. Thank you.
Great. Thank you, Dr. Blue and Dr. McGeorge. So we'll go ahead and take questions from the media. And once again, please raise your virtual hand until I call on you, and then unmute yourself and ask your question. If it's directed to Dr. Blue or Dr. McGeorge, that might be helpful as well. And I did see that Audrey had a question in the chat. Audrey asks, Moderna vaccine held up pretty well against Delta. What do you make of the Moderna CEO saying he isn't sure how well it can hold up against Omicron? And how soon will we actually know the efficacy of existing vaccines against the new variant? That's for Dr. Blue.
Okay, so great question. And as I see a lot of familiar names on the chat in the meeting, and as some of you know who I've talked to, I really try to help you understand where I'm coming from. So with this, first talk about the vaccines. All of the approved vaccines from J&J to Moderna and the Pfizer BioNTech use basically the same template, which is the pre-fusion spike. So they all have the same template. And so when they are administered to an individual, we start to make antibodies. And that's not a one spot on that entire spike. We make a multitude, bell-shaped curve of antibodies directed to what we call epitopes, or locations along that spike. Some of them are directly on the receptor binding domain. Some of them are where the spike has to bend and move. Some of them are close to that furin cleavage site. And so it is not a one size fits all. And we can't say when we vaccinate one individual exactly which antibodies are produced in that person. We have had very encouraging data, and we know this from our what we know about immunology, is that when we boost somebody who's been vaccinated, we not only ramp up the antibodies, encourage the cells that are producing those antibodies to make more of them, we actually expand the breadth. We boost B cells that have epitopes close to or near those. And so we actually will develop antibodies that will be against variants that we have not even recognized yet. So as I mentioned in the opening comments, that when you get boosted after an infection, whether you get boosted after a previous vaccination, we may make antibodies in some people that will work well against this variant. To study this, it is very difficult. We have to take serum from somebody who's been vaccinated. You have to use that serum in a neutralizing assay in either SARS-CoV-2 or pseudovirus that is developed with the mutations that are seen of the variant that you need, and to see if that is able to be neutralized. When you look at those studies, often they include 10 patients, 50 patients, but they're a very low number. And you'll see the spread amongst those individuals is fairly large. And then you look at the average of those, despite having some overlap, and you'll say the average of these is one-fold, two-fold, threefold, higher or lower against this variant than another variant. So back to your first question, the Moderna CEO, I think, is intelligent to say we don't know. And because of the number of mutations, especially somebody who is initially vaccinated and not had their second or third, we won't know the breadth of that antibody response. So as we get the variants and those mutations, I am sure there are labs who are working to put those mutations into a pseudovirus model and will have serum from individuals who have been vaccinated, and will start to be able to try that serum in the neutralization. What we use for effectiveness, which is how does it work in real life scenarios? What you're starting to see is, are individuals vaccinated? Are they coming down with this variant? And some of the reports, as they're trickling in, have been in vaccinated individuals. So if you can do some fancy math and to come up with a way to determine effectiveness, and that's fairly complicated in a test negative control situation, we'll say it may be X effective against this variant. But then there is differences in whether somebody's been infected before that, have they been boosted, how long has it been since they have had their booster or their vaccination series, do they have mild infections, is it totally asymptomatic, or do they have severe disease, is it hospitalization and death? And each one of those will give you a different kind of estimation of its effectiveness. So apologize for a fairly complicated answer to what comes out to we don't know yet, and you'll get a lot of variation in your answer depending on how the answer is derived.
Thank you, Dr. Blue. And does anyone else from the media would have a question? They can raise their virtual hand and I will call on you. And I guess while we wait to see if there's any other questions, I guess one question that I've had my friends ask is if they're due for a booster, should they wait and see if there should be a different Omicron specific booster, or should they just get their booster now?
So I'm not sure who's answering that. I would start with I think it's going to be a while before we know on the Omicron. I also think it's going to be a while for that to be developed if there would be a change in the vaccine. We do know that people who've had the prior vaccines, whether it's just a one vaccine of the Janssen or Johnson & Johnson, or whether it is two vaccines of the messenger RNA, we do know that over time that immunity does wane some. And my opinion is that we're going into the winter season. People are going to be indoors more, and in these super spreader parties kind of thing, that rather than wait, go ahead and get that booster now. Again, it has to have been 6 months since your messenger RNA and 2 months since the Johnson & Johnson.
Yeah, I would just echo that. And in fact, this could be a fairly short conference, because basically the answer to any question right now is vaccination. If the next best answer is testing. And the third is probably way down the list, which is, sequencing of our isolates that are testing positive. So we kind of have a window into what's going on. But vaccination and like the answer to Ms. Dutton, that our present booster seems to actually help with the breadth of that antibody response, rather than going back and trying to be more specific in these mutations, because we don't know whether or not a vaccination against that variant would actually confer protection against Delta. And we don't want to toss that out as well. So that'll be the subject of debate and testing. I can foresee that maybe in the future, for those who are vaccinated for the first time, that there may be a mixture of variants included in that initial vaccine, but that would have to go through a lot of testing. But at this stage, from what I'm seeing in the literature, is boosting with what we have has been efficacious, effective to date on the variants we've seen.
And, I would like to add, the other thing is, when Dr. Blue talks about effectiveness of the vaccine and even with Omicron, not knowing where that's going to be, what we have historically seen, again, even when we do see people getting infections after vaccine, again, the vaccines are highly protective against hospitalization and death. So even if they don't prevent the virus itself, they do still do a good job in reducing the severity of the disease.
Great, thank you. And Audrey, do you have a follow-up question?
I actually have another question, if that's okay. I am kind of looking forward to looking ahead to the future and how the pandemic has affected things. And obviously it's affected pretty much everything. But when it comes to vaccine uptake in general, is there any concern about the kind of polarization of the COVID vaccine kind of creeping into other vaccines? And have you seen any of that at all in Idaho or nationally or anything like that?
Go ahead, Sky, if you.
Okay. So, when often I get the question, are you concerned by, and I guess from where I come from, my job to be concerned, and so, but what I try to turn to is, what can I do about it? And, what data can I point to and show for that? So, certainly on the concern side, we have done so much with our vaccines across public health and healthcare, and probably combined, way more than I've done personally for the number of patients I've cared throughout my career. So, and I'm also concerned by the shift in the why we're seeing the hesitancy. And away from the science and the comparisons of the risks involved, and I can see how we've gotten there, and I can point to a lot of statements on both sides of the issue that have been so cut and dry without acknowledging the concerns and the holes and where our knowledge is still evolving, that it kind of helps to polarize that. So, and partially that's why you might get more nuanced answers from me rather than just yes or no. Although I said the vaccines can be the answer to all of these, I would point out the debate that is often with the side effects of the COVID vaccine versus no vaccine. But I think the debate should really focus on, and Omicron, if anything, points to this, is that variants will continue to happen. SARS-CoV-2 will continue to spread. It'll find a way to spread despite, vaccination and recovery. So it'll find individuals who are at risk. So I think we should really focus on, looking at the risks of COVID-19, the disease, versus the risk of COVID, the vaccine, not the risk of no vaccine and the vaccine, because I think everybody will be exposed to this, whether it's this, go round, next go round, or when we're in the so-called endemic phase. So that's what we need to look at. And we've really come an awful long way with a lot of other vaccines. And I hope to reduce that polarization and get back to what we're really trying to do, which is coexist in a society where we're all looking out for each other, to coexist, not silos of individuals separated. So that's a little bit of a rant in there, but hopefully it kind of addressed your question.
I would add too, I mean, what we see here is more, definitely the hesitation seems most focused on the COVID vaccines. If people put it in perspective and ask the question, would we be comfortable having a 50% vaccination rate for polio? I think all of us would shudder at that prospect. And so I think, so much good the vaccine, whether it's polio or hepatitis or measles, smallpox, all the good that vaccines have done, I think people just take that for granted because we're so used to not seeing those diseases in the US for the most part. So hopefully it won't get to that, Audrey, but obviously we could worry about that.
Thank you both. Okay, so any other questions from our media partners today? I think you guys have done an amazing job of talking about Omicron and the vaccines and where we are today. And of course, we always appreciate your time and engagement and the media for participating. And we certainly hope that everyone, as we go into the holiday season, takes all the precautions that they can and still enjoy the season. And we look forward to our next connection if we don't have any other questions. So thank you both so much for your time.
Yep, thank you.